Ready? So for today's agenda, we will be discussing hepatitis C virus point of care testing and treatment by Dr. Cody Chastain. Oh, hang on. We will also have some case presentations and then also opportunity for Q&A. As always, if you haven't already, go ahead and register with the SEA You can use the QR code, or you can also use the link for today's session. There are continuing education credits that are available if you attend the whole session. Once the session is over, you will receive an email for a post-session survey, and then your certificate will be emailed at a later date. Bear with me, my clicker seems to be delayed. Okay. As always, please introduce yourself in the chat. Include your name, role, organization, and if this is your first echo session. I see that several of you all, I think, have attended in the past, but still, please feel free to introduce yourself. Also, if you do have any Zoom tech issues during this session, please private chat Kimber Miller. And she has also been so kind to include the links to register for today's session. Give everyone just a moment to do that. Oh, we have one person that this is their first echo session. Welcome, Gabby. And Heather, I see you from Knox County. Please feel free to email me so that we can discuss what we discuss at the symposium about treatment. All right. Well, we'll go ahead and move forward with today's presentation. And Dr. Chastain, I will turn it over to you.
Great. So, welcome to those who've been with us before, as well as those who've been this for the first time today. My name is Cody Chastain. I'm an infectious diseases physician at Vanderbilt, and my clinical focus is at caring for people with HIV as well as those with viral hepatitis. And so originally, this topic and this date was aligned to talk about hepatitis C virus advanced medical comorbidities, which we are going to come back to in the near future, talk about distinguishing the difference between advanced liver disease as well as other conditions that might present similarly. But while planning and preparing, there was a new launch and a new component of the HCV guidance. And so we wanted to actually address that and also discuss what that might mean. And so that is what the subject of this presentation is about, is hepatitis C virus and point of care test and treat. Move to the next slide. I do want to highlight, I don't have any pertinent financial disclosures or conflicts of interest. I have funding support from HRSA through the Ryan White Part F grant component that supports AIDS education training centers. And if you care for people with HIV or people who might benefit from HIV prevention services, please reach out to myself, Claire Bolds, or some of the rest of our team members. And we're happy to collaborate and see what we can do to support you. Next slide. All right, so this is what we're going to tackle, I would say, over the next 15 minutes. At the end of this session, learners will be able to first identify resources for simplified hepatitis C treatment. I'm going to emphasize that that is still our primary tool to utilize for most patients. Second, I'm going to describe point of care testing and specifically test of treat approaches that are highly relevant as we think about hepatitis C elimination efforts. And then I'm going to contrast simplified hepatitis C treatment guidance, which we frequently refer to and reference, and this new point of care test and treat algorithm, both logistics, details, but also just practicality. We can do the next slide, please. All right. First of all, like we'll do, I would say virtual show of hands, but I'm pretty sure every hand would go up, whether it would be the Zoom raise hand function or the screen. I think most people on the call, if not everyone, is familiar with www.hcvguidelines.org. This is the home site for the American Association for the Study of Liver Diseases and Infectious Diseases Society of America, HCV guidance recommendations. This has been available for over 10 years. It's frequently updated with new data. And one of the things we frequently refer to in these Project Echoes is what the arrow signifies at the bottom of the opening page, simplified hepatitis C treatment for treatment-naive patients. Next slide. If you click on this area, you get an option to link to either an HTML format or two different PDFs, one focusing on simplified hepatitis C treatment for people who are treatment naive without cirrhosis. That's the document on the left, or simplified hepatitis C treatment algorithm for those who are treatment naive but with compensated cirrhosis, the document to the right. These are slightly older versions of the document. The new versions do not fit on one page, which I still don't understand why somebody hasn't just done some graphic design work to make sure these things still fit on one page. The amount of content is basically one page. But if anybody who's reading really closely knows that these are slightly older because you can tell there's a couple details that are missing. But I think it is amazing to talk about a disease state that is so impactful that we can talk about eligibility, evaluation, treatment selection, monitoring, and what you do for after all on one page. I wish there was something as simple as this for many other diseases we care for. Next slide. If you look at the HTML format, as opposed to the one page, it lays it out as a scrollable page. You got this is an example for treat naive adults without cirrhosis. Starts off with who is not eligible, who is eligible, goes into detail about pre-treatment assessment. And I think a lot of times we talk about the PDF documents or downloads, which are great to print off and post. But the great thing about the actual spot in the guidelines of the HTML that you can scroll down is it's got built-in links for things like go into the FIB4 calculations or directly direct to drug interaction checkers like the University of Liverpool tools. And it goes into additional detail. Next slide. I want to highlight this section, pre-treatment laboratory testing. I'm going to say it out loud because I'm going to come back to it later. Within 6 months of initiating treatment, we should check complete blood count, hepatic function panel, GFR or estimated glomerular filtration rate. At any time prior, quantitative hepatitis C viral load, an HIV screening test, as well as a hepatitis B screening test, and then serum pregnancy testing in the appropriate populations. That is what we consider pre-treatment. That's pretty much standard of care for simplified guidance before starting therapy. Next slide. The rest of the HTML dropdown goes through recommended regimens, on-treatment monitoring, post-treatment assessment, follow-up, as well as for those who are cured and those who are not cured. One thing that I think a lot of people lose sight of is that because we look at the PDF document so often, people miss this flow diagram to the right, which is on the HTML website. They actually have this version. It's kind of a flow of, well, pre-treatment, you do this. On treatment, you do that. Post-treatment, you assess then, which I will note here, assess quantitative hepatitis C RNA and hepatic function greater than or equal to 12 weeks following completion, and then post-treatment follow. This flow diagram, I think, is neat. I wish that we had it as part of the document. I would rather wish it fits on one page. But next slide. That is not what we're talking about today. But I do want to highlight to everybody, you can go to www.hcvguidelines.org, scroll down. You can go to the link that Kimber and play around with that while we're talking. But what we're actually focusing on today is the arrow to download the new hepatitis C point of care test and treat algorithm. And I'll be honest, there's been a lot of data discussion, presentation at meetings about point of care testing, but this kind of came out of left field as far as being showing up in the guidelines. There is not a narrative in the guidelines that actually specifically highlights or supports or discusses this, at least as of yet. Or I should say, as of at least Sunday. Maybe it came out yesterday or the day before. I doubt it. But I want to highlight that this showed up on the homepage and it really discussed, I think, best practices when thinking about point of care testing. And I think it's a preview of where things are headed with hepatitis C treatment in the not too distant future. We can move to the next slide. So, what is point of care testing? Point of care testing is simply testing is done as part of a clinical visit that provides rapid results, typically resulting at a point that is within the same construct of time. A lot of times when we do hepatitis C antibody or RNA testing, it requires phlebotomy either at that visit or at a separate visit that's sent to a laboratory either on site or elsewhere. Antibody test might come back within 24 hours, but RNA testing, whether it be a reflex test or a separate test, might take several days, depending on when the test is run, how the laboratory manages their processes. That typically introduces time and space in between hepatitis C testing and the opportunity to intervene. The idea behind point of care testing is that you could potentially collect data when a person is there in front of you, get results of that data, and then act on that data. Now, point of care testing for hepatitis C has been available for some time for hepatitis C antibody testing. Many people are familiar that there is a company that does oral samples for HIV, or can be done with finger prick, blood samples for antibody testing. And you can get antibody testing, and that's been present for some time. There's also testing that can be collected at point of care, like dried blood spot tests, but typically are mailed off for results that typically have time space delays. But I think what's exciting is that there was recently a platform approved for point of care RNA testing with finger prick capillary blood collection in the summer of 2024. And that was approved in the US, but this system has been approved for use in other countries for some time. And there has been opportunities to couple rapid testing of hepatitis C and, if positive, to immediately pivot to hepatitis C treatments and drastically reduce the gap between assessing a person and subsequently getting them on treatment. And this is what this algorithm speaks to, is an approach that can be done in a clinical environment that if you were to collect this test, how could you subsequently act on treatments? Next slide. So this is a big overview of what is in this document. It's essentially 2 pages. One focuses on the initial visit. The next one focuses on treatment and follow-up. And my next several slides just cuts off chunks of this, and I'm going to walk you through the algorithm. Next slide. So let's start with the test and treat initial visit. So what's on the left is at the top of the algorithm. What's on the right comes right after the bottom of it. So suspend your disbelief for just a minute. We're going to start on the left side. Test and treat initial visit. The idea is that you start with point of care testing that includes hepatitis C RNA testing, pregnancy testing, as well as HIV testing. That is data that from all have validated point of care tests available. And if you get all that data back, the idea is that you could actually take the next step. So if that hepatitis C RNA is positive, the next thing you could go through in your mind is like the simplified guidance. Well, is this a person who's been on treatment before? This person have known hepatitis B? Does this person have known liver cancer? Does this person have clinical evidence of advanced liver failure, ascites, confusion, jaundice, recent vomiting of blood, those types of things? If so, that person, for a variety of reasons, needs additional evaluation and care. Those would not be people who would fit the simplified guidance. So, if yes, then we would go to the right aspect, and on the right side it says specialist consultation. But if not, and the majority of people who present for hepatitis C care do not fit this criteria, you could then go through the next steps of the simplified guidance, which are listed there on the right. Medication reconciliation, what medication could be given at this initial visit. You could draw labs at that visit, including an AST, ALT, platelet count, as well as hepatitis B testing at the visit, not before initiation, but simultaneously with initiation. Also, you can see note discussion of risk of hepatitis B co-infection. We've talked about in prior echo sessions that people with hepatitis B and hepatitis C, if you treat their hepatitis C, hepatitis B can flare and cause severe acute liver injury. But in the same breath, we also need to say that hepatitis B and hepatitis C co-occurring is actually not that common. It does occur, and so we need to pay attention to it. We need to screen for it. But the majority of people do not have both infections. And so to facilitate earlier treatment for at-risk populations, this protocol suggests that as long as you discuss the risks, as long as you obtain the hepatitis B and you have a plan to engage the patient subsequently, you can instruct the patient to start the medicine and will be contacted if hepatitis B is positive, then you could start one of our first initial treatment regimens that are named in their simplified guidance. Glucopropensity for 8 weeks or sulfoxaflor for 12 weeks. There's also an outlet if there's significant drug interactions to pivot to specialist consultation or to at least pump the brakes and discuss with others. And what subsequently happens is after initial visit, if that hepatitis B test returns as abnormal, then you could continue Hep C therapy, but then initiate Hep B therapy or monitor appropriately, which is basically more frequent laboratory testing as per the HCV guidance, as well as engage with a specialist for hepatitis B management long term. But on the other hand, probably 95+% of the time, if not 98 or 99% of the time, that hepatitis B test is going to be negative, and that person will have already started their Hep C therapy and will have it in hand and be able to move forward. So it's a big pivot as far as away from getting all the data back, assessing, making a plan, and then moving forwards. But it does take additional steps of counseling and engagement. I will also note that hepatitis B point of care testing for hepatitis B antigen and DNA is actually under study currently. And so hopefully in the future, this algorithm will change. That if you've got access to point of care Hep C testing, you'll have access to Hep B point of care testing, but that's not routinely available at this point outside of clinical studies settings. Let's move to the next slide. The next slide actually focuses on follow-up. And this is a big difference. As most people who are on these echo programs have been reminded, there's actually no recommendation for routine laboratory monitoring on therapy. We check it for patients who are symptomatic, who have severe laboratory abnormalities to start with, if there's a question of adherence or special cases like hepatitis B co-infection. But we don't routinely check it. Usually we check labs 12 weeks or more after completing. But in this test and treat protocol, actually the recommendation is to check hepatitis C RNA testing 4 weeks after completion of therapy. The idea being that most people, if they are negative with a hepatitis C RNA test 4 weeks after completing therapy, the vast, vast, vast majority of them, 98 to 99%, stay that way. And the idea is if it's negative, you could counsel them about sustained virologic response. And if they have evidence of advanced fibrosis that was available prior to treatment, those patients could be monitored accordingly. And if not, those patients, as per simplified guidance, do not need further monitoring. On the other hand, if hepatitis is detected 4 weeks after completing therapy, then that patient may benefit from repeat treatment. So specialist referral in that context may be appropriate, or engagement like this program with experts can talk about retreatment. Let's move to the next slide. What you might have noticed in looking at those 2 pages that there's 3 big call outs or caveats on that second page. First of all, they actually says that AST and ALT and platelets can be deferred if you actually have sufficient staging information prior. I think the likelihood that any person has had a transit elastography test done, but no AST, ALT, or platelets done in the prior 6 months, I think is really unlikely. But in theory, if you know how much scar tissue is in that person's liver, you probably don't have to have those labs ahead of time. They have a big caveat about unrecognized active hepatitis B, and we already talked about that. It's incredibly important that if we were to start Hep C therapy and a person that we do not yet have their hepatitis B diagnostic testing, that we test for hepatitis B, we include the patient in counseling, and we have a clear-cut plan about how to engage that person by phone or by some other communication so that if their hepatitis B test returned positive, that we can engage them in therapy. Last but not least, there's this comment about follow-up testing, saying that quantitative RNA testing is preferred, but qualitative testing could be used. They also have this caveat about you could choose to check hepatitis C RNA at week 4 if there's a question about adherence. And then they say, well, in addition, evaluation of SVR12 should be done for people with cirrhosis. But interestingly, they didn't comment at all here about doing SVR at 4 weeks. There's nothing in the protocol, there's nothing in the guidelines. But what I can tell you is that most of the time in studies, week 4 after completing treatment correlates well with week 8 and week 12. There are a very small number of people who have a positive RNA test at week 8 or week 12 that had a negative test at week 4. But I think the idea behind this guidance is trying to facilitate more treatment for more people earlier to get rid of barriers and short, to echo one of my favorite phrases, to not make perfect the enemy of the good. Getting more people on treatment, getting more people on treatment faster before they could potentially be lost due to barriers could be a better strategy than committing to doing the best thing, but only doing the best thing for a handful of people. We move to the next slide. So what is the difference between the HCV guidance and test and treat? Well, simplified guidance focuses on pre-treatment labs obtained and food prior to initiation. Hepatitis B is identified prior to initiation and addressed before starting hepatitis C therapy. And hepatitis C cure or sustained virologic response is assessed 12 weeks or later. This test and treat algorithm suggests getting pre-treatment labs at the same time as initiation. Hepatitis B is, labs are obtained, but it's identified after initiation and then subsequently addressed. And SVR might be assessed at 4 weeks. So those are the big tangible changes. Next slide. So I will get a little bit of interactivity here and we'll use the chat function. I will stop for questions here in a minute. Sam's a 23-year-old woman who presents her recovery program for opioid use disorder. That program has purchased one of these point of care testing platforms, and rapid hepatitis C point of care testing is positive. Sam is going to be intensive inpatient and then outpatient rehabilitation services for the next 4 to 12 weeks. So, first question, I'll just keep my eye on the chat. Is Sam eligible for hepatitis C test and treat based on the information I presented? Or maybe I didn't give you all the information. Is there more information that you need to know if Sam's eligible for hepatitis C test and treat? You can also, I will say, you can put it in the chat. You can also come off mute. Or if you want to pose it as a question, so that I don't judge the answer, that's also okay too. Rajiv, is she pregnant? Rajiv, always love it. And Bill said need more information. So pregnancy testing, that's one of the key things that we identified earlier. Does she have any symptoms? Is there any evidence advance or liver disease? That's so important. No, is there more history? Has this person been treated before? Maybe this person was on therapy at a different rehabilitation program that discontinued halfway through the therapy, or after completing therapy started. What other medications could be on? So I think what we could agree on is that Sam is the type of person, and this is the type of program that could benefit from a point of care test and treat program. Yet we do need a little bit more clinical information. And that goes into the second one, what questions need to be asked, right? Background history, prior treatment history, any evidence of advanced liver disease, any known other medical problems that are a barrier. I think those are all critical. So just as a quick review, let's say that Sam is not known to be pregnant. We actually do a pregnancy test that's negative. What other tests would need to be obtained now if we were going to think about point of care test and treat? Hepatitis B, yeah, I'm hammering on this. We got to get a hepatitis B test of some capacity. HIV test is actually essential as well. Remember, that was actually one of the first things right out of the gate, along with the hepatitis C point of care testing and the pregnancy testing. I think that the good news about this is that actually probably more testing doesn't have to be done to consider treatment, provided we've got answers to those other questions. But additional concomitant tests, if you don't have staging data, which most of the time we won't, a blood count and liver function tests like an AST and ALT could be helpful for calculating things like APRI scores or FIB4 scores. Additional, that we already mentioned, the HIV, hepatitis B test, but there's not a lot of additional testing that is necessary. So I mean, I think this is an exciting way to pivot and think about this process. Next slide. So there is a lot of potential with the strategy, but there is a reality. Access to point of care testing is currently limited. This requires a laboratory platform that can run HIV rapid testing, Hep C rapid testing, and potentially in the future Hep B rapid testing, but it is currently limited, and an organization has to commit to purchasing and or procuring this as a tool. But I think the big challenge, at least in the domestic US, is that at least in Tennessee, we do not live in a region where we have relatively unfettered access to Hep C therapy. Some countries, some programs, but also some states have actually purchased hepatitis C therapy at a subscription model rather than paying per prescription. They actually paid for unlimited access to therapy, and that's really facilitated these type of treatments. Today in the United States, if we were to have one of these machines, it might allow us to assess people quicker. But the reality is that for people who have a payer involved, insurance, whether it be a private pay program, a public plan, an exchange plan, Majority of the time, prior authorizations remain a barrier before being able to get that medicine filled. Patient assistance programs also take time to get information. I will say that's really interesting that the guidance here suggested pregnancy testing up front, but it doesn't really explicitly discuss pregnancy after the initial testing. We know based on our simplified guidance, pregnancy should be a carve out and considered differently. But it'll be interesting to see how this is addressed in the future. And I will say it's a real one of the big things about this guidance for me that I've been talking to a lot of people is should we just do SVR4 for everything now? They put this out there. There's no additional support that we do have data suggesting that you'd probably have to test somewhere between 500 and 1,000 people, depending on what study you look at week 12 to catch one that would have changed from week 4 to week 12. So let me frame it a different way. We could have 1,000 people at week 4, and if they all test negative at week 4, we would be correct for 999 of them or 998 of them, that they will still be negative at SVR12. Is it reasonable to continue to facilitate our program with these long tails? It's a question. We can move to the next slide, and this will pivot into our questions and discussions. So this is a novel approach for rapid engagement care. It's not novel in other countries, but it is being put out there into space to be considered here and to be supported based on guidelines with this can improve linkage care, initiation therapy, and subsequent care. It's a new algorithm, but there's limited discussion and data in the guidance itself, and there remain significant barriers. And I will just echo Dorinda's comment, and I'll give as many thumbs up as I can give, is that this is just one more tool to basically discuss with payers at systems levels that why do we need genotypes? Why do we need as many steps with prior authorizations? Why is this necessary from a clinical care standpoint? And so with that, I think my next slide is just a question mark holding slide. So thank you for your attention and time. I'll pause here for questions from Lindsay, questions from the team. You can type things in the box or you can come off mute and ask it verbally. More love for Dorinda
Dr.
all the
Chastain, I
way.
have a question.
Yes, please.
While I'm hopeful that some others may come off mute too, but what about the cost of this particular point of care test?
So the cost per test to be conducted is, I think, at scale estimated between $50 and $67. Now, they're having cost effectiveness models looking at this strategy, and that this strategy is actually cheaper to use point of care RNA testing in high prevalence populations. Now, high prevalence can be anywhere from 10% to 90%. Some of you who might serve in a public health department for underserved populations or that might work in a substance use recovery program might recognize that your prevalence is actually higher than 10%. And if that's the case, then actually this is often a cheaper strategy if integrated in care. Now, but the problem I think for this is the capital expense of purchasing the machine up front. And I actually do not have a quote or clarity for you on that. This was recently FDA approved in this past summer. I actually worked on an NIH funded program about doing the study for validation. So it was not from the manufacturer of the company, which is why I didn't list as a disclosure. But it's I think it's important. Cost is a important but should not be a prohibitive strategy, particularly in places that I think this could be most effective. Substance use recovery locations, neo-exchange programs where people return for care, places that have integrated additional services. I think that's the optimal, and that this could be a cost-free strategy. And I know that some organizations have purchased machines with grants and with plans of pursuing things in this regard. I'll go to Dorinda's comment. I presume that this rapid PCR technology was improved during COVID pandemic. Machines are very expensive. Then you buy cartridges. You are exactly right, Dorinda, is that the platform for PCR testing at point of care was leveraged based on a lot of the studies and development of rapid PCR testing for things like COVID, but have now been applied to influenza and a variety of other point of care testing, which also means that a clinic might actually utilize this for far more than a single hepatitis C test, might be utilized for a variety of point of care tests that might be relevant for primary care. Rajiv.
Hey Cody, awesome information as always. My question is like related to it's like when you were describing this, what I was kind of like popped into my head is almost like that rapid start that we did for HIV. And I was wondering, I know there's the payer question related issue with just hepatitis C alone, but if you have somebody who's like co-infected HIV hepatitis, is it possible to potentially move down that rapid start for hepatitis as well under these kind of like guidelines, you know?
Yeah, I think it's a great point, Rajiv. I think that, and we recognize that in certain states and certain locations, people who are diagnosed with HIV get plugged into a system of care that has been developed and supported through things like the Ryan White program or others. And actually, barrier to medications is not the primary barrier. We don't have something like for hepatitis C, but could we imagine that a rapid start type of program could be done concomitantly? I think there are additional layers of challenges that might be in doing rapid start HIV and hepatitis C therapy and a person newly diagnosed with HIV. But the idea about developing a rapid start hepatitis C treatment program has a lot of analogies to HIV rapid start, with the major difference being that most people with newly diagnosed HIV have a guarantee of a payer resource, whether it be a Ryan White program or another resource. But I think there's a lot to learn from those programs. Most of the places I know they're doing these type of programs in the States for Hep C are in states that have models that will allow more rapid access to medications, are existing in systems that have access to that, whether it be incarcerated populations or others, or they actually have pursued this through additional grant work, saying that our fairly qualified health center or at our substance use recovery program or our location, we've got this machine. We want to do this, and actually are doing industry supported trials with a medication access.
Great questions. Thank you, Dr. Chastain. For the
Yeah.
sake of time, oh, did someone come off mute or was that you, Dr.
No, I just
Chastain?
was laughing. I was laughing at Duran's
Okay.
comments. And many other states have put a lot more money into this, have streamlined the process of medicating businesses. And I would, so speaking on behalf of Tennessee as a Tennessean, I would agree, Duran, that we have not had the same degree of energy and or investment as some of our peer states, but yet we can also learn from those. And we also have sometimes people here participating from other locations across the Southeast and others. And I think we'll look forward to learning from all you too. And Lindsay, you were going to pivot us to the cases, which is great.
Yes, I think towards the end we should have an opportunity for additional questions. If anyone wants to come off mute or put any in the chat, we can address those. But otherwise, we'll go ahead and move to the first case. Great conversation, though. All right, so I'm going to